So our next session will be on the Pharma Research Symposium, the Advancing PN in Aesthetic Practice, Expanding Application and Treatment Strategy. So our speaker will be myself and Dr. Tolafumi Yao and Dr. Devin Lims. Will you please come up to the stage? Hi. Hi, how are you doing? Okay. So I think because we actually already over time, so I will start my talk. So my first talk will be on from collagen to complexity PN, ECM mimetic remodeling and toxin, using PN as the ECM remodeling and toxin in melasma. Let's see, was it my hypothesis? When we see melasma is, we know that it's notorious in terms of the recalcitrant, it's difficult to treat, and highly labs, and is found rebound hyperpigmentation after the treatment, particularly in Asian skin. A lot of time it worsens after the treatments, and you can see that some patients have persistent erythema. So if you look at this, you see that more than 50%, 60 to 80% found relapse within 6 months after stopping the treatments. And we found that there is a more than 80% of the lesions showing basement membrane disruption. So the treatment that we do by targeting only the pigment, only the melanocyte and telocinate alone, it cannot break the chronicity of melasma. It means that you would get like not success in melasma treatment, because melasma is not just about the pigment. Melasma itself is a dermis, is a dermal disease. It is a chronic dermal microenvironmental disease, which there's a crosstalk between epidermis and the dermis, including the vasculature, including the immune and neural system, which is actually is beyond the pigment. It communicate with other cells. It's not just melanocyte, but it also interact with keratinocyte, interact with the fibroblasts, interact with vascular endothelial cells, mast cells, and sebaceous. And those are the cells which interact with the melanocytes. So if you look at the dermis, the pathology in the dermis, which is found in melasma lesion, which are solar elastosis and basement membrane disruption, and senescent fibroblasts, including the SASP, and the mast cell hyperplasia with neurotic sensitization and vascular hyperplasia. Those are important 5 sustaining a dermal pathology. And if you look at melasma, there's many things going on, in those cells, not just melanocyte overactivity. You see that there is a pro-inflammatory, pro-pigmentary factors, there are pro-inflammatory cytokine and growth factors showing in the sebaceous and also the fibroblasts. You see that there is a pro-inflammatory cytokine and senescence marker, and also the abnormal vascularization in those cells. So those 5 cells actually leads to the complexity of melasma. And the hypothesis that I have here is a axis of the neurovascular barrier matrix axis. And that is a axis which is lead to the chronicity of melasma. But when we're talking about the PN, or polynucleotide, I would like to place these slides to differentiate between PN and PDRN, so we have a clear idea of what different between those two, so we don't confuse when we're talking about those substances. It actually has a structural similarity because both are DNA-derived biopolymer, but it differ significantly in terms of physical properties, in terms of length of polymer, including molecular weight, and also the primary mechanism of actions. With the polynucleotides, it had a longer DNA fragment and a heavier molecular weight. And the most important structure, which is different from PN and PDRN, is a scaffold effect. So the primary mechanism of actions of the PN, the key role is in the structural ECM remodeling. While the PDRN is, the DNA fragment is shorter, molecular weight is less, and is no scaffold appearance, which the primary mechanism of PDRN is more on the pharmacological drug, which is via the stimulation of A2A receptors and the nucleotide and support nucleotide synthesis via the SAWAT pathway. And also, PN from different brand, we actually different because it's different sort, different purification, different polymerization, different stabilization method, and also different viscoelasticity, including the different in terms of structures. But basically, when we look at the PN, we're looking at the high viscoelasticity, which is formed as a cohesive hydrogel as a structural support. And it's showing the intense hydrations at with the physical scaffolding, which has distinct, unique properties. It also shows intense hydration as a scaffold effect. It's formed like a device-like ECM support with the PN structures, but different from the PDINs, which is more like a biochemical mechanism of actions. So when we're looking at, in this presentation, I will, my hypothesis is combining the treatment with PN with the botulinum toxin by focusing on the microenvironmental health based on the NVBM axis, but with the different idea. With the PN, we look in PN as a matrix primary agent because we address over the ECM dysregulations and solar elastosis. Why, when we look at the botulinum toxin, this is more like a neuroprimary agents. We address over the stress UV trigger neural and vascular loop. Now we go to the look into the botulinum toxin as molecular pharmacology in the skin by going through all the axes. The main molecular actions of the toxin is over the SNAP25 cleavage. So its primary action of the botulinum toxins is over neuropeptide silencing. So it's showing that decreased GRP, decreased inflammatory marker as a substance P and acetylcholine from the peptidergic and cholinergic C fiber in the dermis, and also helps in decrease in VHF expression in the melasma lesion, as helps in vascular blockage and stabilize mast cells, including decrease in inflammation by several pathways. With the PN scaffold, it more actions on the matrix axis effect. It helps to restore ECM fragmentations. It helps in the fibroblast senescence through the YAP-TSE pathway and also through the SASP loop. So it helps in solar elastosis. It also involved in MMP2 and 9 activities. It also has effect on others axes as the neurovascular barrier axis. With the neuroaxis link, we found that in melasma lesion, it's showing nerve hyperexcitability. If you look at melasma dermis, there's depletion in the extracellular matrix. And there's this hypertransmissive interstitium in the dermis in melasma lesions. And, okay. It's shown that in the melasma lesion, it shows neurogenic inflammation through the activations, through many neural activation cascade. At the UV heat, emotional stress, we know that this can activate the sensory nerve C fiber. It also showing neuromelanocyte crosstalk, neuropeptide loop. As all the inflammation marker in the melasma lesion like substance P, CGRP, and GF release into the dermis and syncytium. It also has a neurogenic inflammation through the mast cell nerve crosstalk. So those inflammations is actually will create more of aggravation of melasma. And also, when we look at the PN actions and botulinum toxin A action on the neural axis, the PN scaffold action has many properties which help to restore a buffer, the viscoelastic buffer between the cells, between the nerve terminal, between mast cells, and between perivascular structure, that we help to reinstate the soft viscoelastic institution. And also it helped by, when combined with the HA, it also helped to reduce perineural frictions and also help in mechanical perturbations of the C fibers. It helped the nerve fiber to less sensitive. It also helped in volumetric expansion of the triad spacing, restore the dermal volume, re-expand the nerve vessels in the mast cell triad. But with the botulinum toxins, it showed the different mechanism in terms of neuropeptide silencing. With the botulinum toxin A, it has a light chain endopeptides, which is cleavage of SNAP25. So it blocks vesicle fusions. There will be less of CGRP or substance P or acetylcholine release. It will help to stabilize a mast cell, which is part of mechanism of actions. When we look at the botulinum toxin A, it also affects melanocyte and mast cell in two direct mechanisms of actions. It also had the direct effect on melanocyte. It helps in blocking UV-induced pigmentation, both in vitro and in vivo. It blocks acetylcholine release. It helps in release the. It helps in blocking acetylcholine release, which is affect the melanocyte nerve crosstalk. It also reduces melanin synthesis, decrease in ITF, decrease tyrosinase activity. And also with the botulinum toxin, it also have direct mast cell effect. It inhibits the compound 4880 induced degenerations. It also affects several pathway of mast cells. It has an action, different vascular axis actions, both in PN scaffold and in botulinum toxin action. The PN scaffold with help in perivascular ECM restoration, stabilize vessels, and also helps the scaffold occupancy, special EVGF normalization. With the botulinum toxin A, it helps to, through mechanism of decrease in substance P, extravasation, and also helps in decreased VEGF expression and target over the vascular phenotypes. It's all about the mechanism of action, but basically the basement membrane, the B axis, which is basement membrane disruption, when we looking at melasma lesions, we see that there is a chronic UV inflammation, decrease in MMP2 and MMP9 degradations, and this will lead to the basement membrane disruption and create pendulous melanocytes, and it will create the pigment incontinence that will showing that there is increase in pigmentation, including increase in transepidermal water loss. Burial axis. It's also shown that it has the effect of PN scaffold held in burial axis by several of mechanism of action, including the matrix degenerations, okay. I'm sorry, the slide is not the same slide. Okay, anyway. So that's what, because of NVMB matrix axis leads to, the problem is why monotherapy is failed to treat with other modalities. For example, with the modality like a topical treatment, you not be able to treat the whole axis, you only be able to treat only the pigment. Or using a laser or IPL, you only treat the part of the pigment. And with the botulinum toxin A, you only be able to treat the neural exits only. The main target of the toxins is only for the neurotoxins, while you can also have the effect on vascular exits and basement membrane exit. With the PN as a matrix primarily, you can only treat, you can help to treat the matrix, but with the others axis, it doesn't really affect that much. But with those two combinations, it helps to combine those two. Because the complexity of the melasma, there are many of, I'm sorry. Too tired, okay. Because of melasma, there are many of etiology. The etiology is so complex. So when we want to treat the melasma, it's really important that we are able to cut off these pigment loop. So with the different modalities or treatment, as polynucleotide can help to repair of the basement membrane and regenerate of the ECM and restore epidermal barrier receptors that will help to remodel a damage over the matrix. While the botulinum toxinase help to stop the neurovascular signaling, so it more kind of calm of sensitivity of the neuron. So it helps to create better result. So the protocol is actually using botulinum toxin A. When we look at when we decided to treat with what, it depends on the clinical side that we see. For example, if we look at the melasma and then we see the persistent erythema, then we'll go for the botulinum toxin instead of doing others. We will go for botulinum toxin first. We see persistent erythema, we see more telangiectatic appearance, then we select botulinum toxin. But when there is a refractory pigment and there's more elastosis, more thinning of skin, then we're looking at how we treat the matrix by using the polynucleotide as a improved fibroblast senescence and to help in basement membrane collapse. And this is the way that I do it, and this is the product that I use, which is you can use the HB very superficially, intradermally. And this is a toxin. We actually will inject very, very superficially. You see that the needle itself is so superficial on the skin. It's almost like parallel to the skin with the needle. Needles just, try to parallel to the skin and then alternately inject like in between the PN. There's many scenarios when you use combination. You can use toxin first and then you can use PN, or you can do the same session and the dual treatment, or you can do PN first and then you're using the toxins. But importantly, we don't mix in the same syringe. And this is a before and after treatment. And this is a combinations. This is only the PN treatment. You can alternate the PN treatment and toxin injections. So basically, basically melasma is not just the pigment. So we have to be able to rebuild the ECM or remodel the ECM dysregulations and retreat the extracellular matrix to create a better skin and including the healthy environmental skin to have a better healthy skin to create more better hemostasis in terms of NVBM axis. Sorry, yes. So, okay. So melasma is a complex dermal communication failure, which is can be driven by NVBM axis. It's created by it can create by senescent fibroblasts, basement membrane disruption, neurovascular proliferations, and with the PN, it can help to in terms of ECM mimetic remodeling. It helps in melagenesis and intradermal toxin injections. It helps in neurogenic inflammations. So regenerative medicine is seemed to be an answer for recalcitrant melasma, and the future is not suppression melanin melanocyte anymore, but it's more like try to remodel a cellular biology. Thank you.
Hello everyone. Today I would like to share how we expanded the use of Ridgerun series product in daily practice, how we select products, how we select delivery methods, and why Ridgerun has become one of my favorite treatment platforms. Most importantly, I will share real-world experience rather than theory alone. My name is Torfumi Yao from Japan, Shonan Beauty Clinic. I love Ridgerun. In my face, I have almost 50 Ridgeruns in my face. My face is made of Ridgerun. Thank you. Before talking about products, I would like to start with a personal story. Ridgerun is not simply a treatment that I provide. It is a treatment that I personally choose. So today, I would like to explain why. This is a COI disclosure. This was my skin a few years ago. Acne was my main concern. Like many patients, I struggled with repeated breakouts. And then acne finally calmed down, but the story did not end there. I also felt that my skin was not where I wanted to be. And I think many of our patients feel the same way. What came next? Two concerns remained. One, acne scars, and two, skin quality. At that point, I started looking for another option. What would you choose? I had already tried several treatments, needle RFs, fractional lasers, and other energy-based procedures. They certainly helped, but personally, I still wanted something more. So I asked myself, what would I choose next? I chose Ridge-Run series. What attracted me was flexibility. That flexibility became increasingly important in my practice. For me, Ridge-Run family is not just one product, it is a platform. First, we can tailor treatment by product selection. Second, we can tailor treatment by delivery strategy. These two dimensions allow us to customize treatment for different patients. Let's start with product selection. Today, we mainly use 4 products within the Ridge-Run family. Each product has a different role. And rather than asking which product is best, I prefer to ask, which product is the best fit for this patient? Let's begin with region I. The periocular area is one of the most challenging regions to treat. The skin is thin. Patients notice everything. Even small papules can become a concern. Because of its lower viscosity and lower papule visibility, region I became a preferred option for fine periocular wrinkles. This is a representative case. 1 month later, 1 session. When I evaluate these cases, I don't focus on a single wrinkle. I look at the overall appearance of the skin around the eyes. The goal is improving skin quality in a very delicate area. Around the eyes, regional eye works well, but when patients start asking for broader facial treatment, the challenge changes. Some patient says, "Oh, it's too hurt. I can't continue." It is no longer only about product selection. It becomes about treatment, comfort, and repeatability. This is where Ridge-Run HP Plus became very useful in my practice. It contains lidocaine, which supports a less painful treatment option. That makes broader area treatment more practical. It also contains non-cross-linked hyaluronic acid, which adds immediate dermal hydration. So for me, HP Plus expanded the treatment area. This is my photo. This is a representative HP Plus case. 1 month after 4 sessions, performed by Dr. Soichiro Morikawa. Clinically, HP Plus helped me treat broader facial areas more comfortably. That is why this product expanded my options. Next, not all concerns are broad or diffuse. Some problems area localized. For example, atrophic scars, dermal volumization needs, deep neck creases. These are not the same as general skin quality concerns. They require a more targeted option. This is where Ridge-Run S fits into my practice. Its physical characteristics make it useful when I want more localized support. This is my own acne scar case, performed by Dr. Soichiro Morikawa. For me, this is one of the most personal parts of this lecture. After acne improved, the residual atrophic scars were still frustrating. Energy-based devices were helpful, but I still wanted another option. Region S became one of the treatments I chose for these localized depressions. Our clinic use did not expand all at once. It expanded step by step. First, Region I was used mainly around the eyes. Then combination menu appeared. Later, HP plus related menu expanded. Then Hycox-based delivery was introduced. And finally, Region S was added for more target concerns. So this timeline reflects a very practical process. Patient needs expanded under menu design. So why add low-dose Botox? The goal is not to freeze expression. The goal is not traditional muscle paralysis. The concept is skin quality treatment with an earlier visible change. Region-based treatment supports skin quality. Low-dose botulinum toxin can add an earlier visible change. Together, this became a practical combination in a daily practice. In 2025, combination menus became very common in our internal records. Especially region-based treatment combined with low-dose botulinum toxin was frequently recorded. For me, this reflects real-world demand. Patients want skin quality treatment, but they also want visible change within a reasonable time frame. At this point, we had several product choices: Region I, HP+, S, combination menus. But product choice alone was not enough. The next question was delivery. How do we deliver the treatment efficiently? How do we reduce treatment burden? How do we make broad area treatment more practical? That is why delivery choice became the next major theme. Manual injection is still very important. I use it often, but it has limitations: pain, downtime, cost. When we treat small areas, these issues may be manageable. However, when we treat broader facial areas, these limitations become much more obvious. This is where delivery strategy starts to matter. Hycox made broad area practical. The key points are simple: cost advantage, treatment efficacy. For full face treatment, manual injection can be time-consuming and burdensome. Hycox made broad area delivery more practical. So in this section, I want to show how delivery choice changed our treatment strategy. This is a representative case using region plus low-dose botulinum toxin with Hycox. Here, the main message is not one single lesion. The message is broad facial delivery. Hycox allowed us to apply this combination over a larger area in a practical way. This is a good example of how delivery strategy can expand what we can do with the same treatment concept. But there is still a trade-off trade-off. Even if Hycox makes broad area delivery practical, immediate post-treatment findings can still be visible. You can see redness and visible treatment marks immediately after the procedure. For some patients, this is acceptable. For others, this becomes a barrier. So the next question is, can we offer another option for patients who worry about needles or downtime? Some patients are not only concerned about results, they are concerned about the process. Needle fear is real. Downtime concern is also real. Even if a treatment is clinically reasonable, patients may hesitate if the procedure looks so invasive. So we needed another answer for this group of patients. CureJect opened another door. The message is very simple: needle-free, downtime conscious. This is not meant to replace every existing technique. It is another option. In a group, this has been used only in a limited number of clinics since 2025. But for selected patients, this type of delivery option can be very attractive. Here is an immediate post-treatment example. The key point is the visible post-treatment appearance. Compared with conventional needle-based delivery, This type of approach may be easier for patients who are concerned about visible downtime. Of course, this is not a guarantee of no downtime, but it gives us another option to discuss with patients. This is the same concept at 1 month. Again, I do not want to overstate the conclusion from a single case, but clinically, this helps show why a needle-free delivery option can be meaningful. For some patients, the acceptance of treatment is just as important as the treatment itself. If the patient is more willing to start and continue treatment, that matters. This slide shows published supportive evidence. In a small split-phase study, the reported pain source was lower than Curaject compared with manual needle injection. The VAS pain score was 5.4 on the needle side and 2.9 on the Curaject side. The difference was statistically significant. Patient satisfaction was also reported to be higher. However, this was a small study with only 10 patients, so I present this as supportive evidence for clinical use. So far, we discussed product selection, then delivery selection. But for routine clinical use, flexibility alone is not enough. We also need reassurance. When we use a product repeatedly in daily practice, we need to understand the material, the manufacturing concept, and the real-world safety context. That is why I want to briefly discuss PN and DOT technology. Region is based on salmon-derived DNA fragments. The important idea here is biocompatibility. This material concept supports clinical reassurance. Of course, this does not mean zero risk. But when choosing an injectable product for repeat skin quality treatment, the material concept matters. For me, this is one of the reasons Region is attractive in routine practice. PN and PDRN are related, but they are not the same. PN has longer DNA chains and higher molecular weight. PDRN has shorter DNA chains and lower molecular weight. This difference can influence water retention, viscoelasticity, and clinical role. So I do not explain this as better or worse. I explain it as different molecules with different characteristics. This is a clinical translation. PN is more aligned with skin bursters and dermal remodeling. PDRN is more aligned with wound healing and anti-inflammatory contexts. Both can be useful, but the clinical role is different. For skin quality treatment, hydration, and dermal remodeling concepts, PN fits the treatment goal very well. This slide shows the structural difference. PN has a polyhedral scaffold-like structure. PDRN appears more amorphous. This helps us understand why .PN is not just another DNA-based material. Again, this is not a claim of guaranteed clinical superiority. It is a mechanistic explanation of why the material behaves differently. DOT is important because quality control begins before injection. The process includes molecular weight-based separation, controlled manufacturing, impurity removal, and consistent product quality. These steps lead to a highly defined 3D polyhedral scaffold. For me, this is important because routine clinical use requires product consistency. Now, after discussing the material and manufacturing concept, the next question is simple. How about real data? In a 2025 internal review, we evaluated 78,553 patient days. The overall reported complication rate was 0.028% or 22 cases. Mild to moderate events accounted for 18 cases. Severe anaphylactoid type events accounted for 4 cases. Importantly, in this internal review, no reported vascular occlusion or late onset nodular granulomas was reported. So why do I continue to choose Regeneron? For me, the answer is patient-centered customization. One series can meet diverse patient needs. We have real-world safety context from our internal experience. And we can customize treatment by both formulation and delivery. Product choice, delivery choice, patient needs, doctor strategy. That combination is the biggest practical attraction. This is why I love Regeneron. Thank you for your attention.
The last one, last speakers. Thank you. Dr. Devon Lim, you talk about the complex skin quality case, pigment redness, texture, scarring, the clinical consideration for Regeneron, including energy-based device combinations and safety considerations.
Thanks for that. Hey, thank you very much, Achima. You had a really hard job with all the molecular science with it, as well as the biochemistry. Reminded me of my days when I was doing my derm exams, and we have to talk about substance P, MMPs, TIMs, and all that.
The reason, and I'm trying to explain in mechanism of action in deep into the science, because I want everybody to know that this is not the marketing hype.
Yes.
And we know that there are a lot of debates about PN as a marketing hype instead of the science behind it. And actually, there's a science behind it. But I'm sorry I didn't do a good job today because
I think you did an excellent job. You've done so much for this meeting, so I can tell.
Sleepless night for many days, actually month, to organize this meeting and also, try to make everybody happy.
No, all credit
Yeah.
to you. Okay, guys, so I'm going to give a quick summary of this. And like I said, Achima's made my job a lot easier. So there's a saying, give a man or woman a fish and you will feed them for a day, but if you teach them a fish, you feed him or her for a lifetime. So today I'm teaching you how to fish, right? And the logic behind why I use Regeneron in particular with my treatments and the logic and timing of EBDs, energy-based devices. So I've learned a lot over the years from my Korean counterparts because I've had Regeneron a decade more than what I have. I've only had experience over the last 4 years, but it is the injectable of choice in my practice. So the majority of dermatologists, we all combine Regeneron with our EBDs, right? And when you look at devices, you can take a photo of this, but basically any device you can think of, it can be combined. All right, and there's a logic behind that. So both the speakers have gone through the structure of Regeneron, which makes my job a lot easier because when you look through the EM electron microscopy, Michael Kim did this, it's mainly an amorphous structure, right? And it provides scaffolding. So when you look at injectables versus biostimulators, this is my opinion only. Where does it stand in the context of what we do? It's this. It does a little bit of everything, all right? It gives you a tiny bit of volume, possibly because of the breakdown from your polynucleotides to nucleotides, hydrating effect, right? Because it's a little bit hydrophilic. Gives you a tiny bit of collagen stimulation, right? So in the scheme of all the injectables we do, tiny bit of everything, right? Now, when you look at the word biostimulation, and I think it's a buzzword, right? But when I try to make it very simple, anything which stimulates collagen, right? Whether it be an EBD, your injectables, your low-level emission devices, everything that stimulates collagen, it's going to be some kind of collagen stimulation. So if I put it simply, when we look at collagen-stimulating injectables, you don't have to worry about the pathway, right? Whether it be low-inflammatory pathway. When we talk about things like your energy-based devices, your high-energy-based devices, your CO2, your erbiums, and all, they have a unique pathway, right? Which is a little bit different from every other pathway. So when you look at, that's probably heat shock protein more than cytokines. And when you look at the cytokine pathway of the non-ablative lasers, It's complex, but they all produce some kind of collagen remodeling. And then when you look at your pico lasers, it's different still because it's your LIO beads which provide a different cytokine pathway. So what I'm trying to get at is that it's a little bit of everything. And even with your collagen stimulation with your PNs, like Achima says, right, your PDRN is more towards your nucleotide salvage pathways. In other words, your nucleotides are broken down, and it's basically food for regeneration, right? And the other thing as well is the receptor, A2A receptor, which has been noted. And it has a little bit of an effect on your endothelial cells as well. But most of us agree throughout this entire lecture that it provides some kind of scaffolding for your ECM. So if I'm going to provide it really simply, it's this, right? If you look at whatever pathway, heat shock protein, cytokine, foreign body, whatever pathway, it may activate the fibroblast. It gives you a collagen, right? And what you want is a scaffold. So when you combine it together, more collagen and better ECM support, you basically have something like this, if I can just simplify it. It's very simplified. Whatever collagen pathway you can think, if you add a little bit of ECM support to it, you get a stronger matrix. Right? That's my view on things. Now, so for me, Regerin is used to complement collagen induction pathways, whatever pathway you choose, right? I employ it in all pathways, except for the highly inflammatory foreign body pathway, some of the biostims, but that's another lecture, okay? Now, what combinations do we use and who are the suitable candidates? So when I look at things, we can use it for treating eye rejuve, dark circles. We can use it to treat skin quality in combination with your devices. We can use it, as Achima says, for your melasma patients. We can use it for scarring. We can use it for eye rejuve, right? So when I'm going to put it really simply, for eye rejuve, I like using Regerin Eye. Why? Lower viscosity, right? It's small needle. Same PN concentration, but it's not as thick, so it dissipates a little bit easier. Now, big debate, which one do you want to use? You want to use cannula or do you want to use needle, right? I'm going to put it simply as this, and I'll show you the differences, right? So how does it work? First of all, provides a little bit of collagen stimulation, as we discussed. It improves the elasticity, improves your hydration. So when you put it in your under eye area, you can see a tiny bit of volume, right? It reduces inflammation. It has novel effects on your melanogenesis. But when you look at it, even at 1 week, it reflects a bit of light, right? And for me, I think what's happened is that it's taken a little bit, because it gets broken down, a little bit hydrophilic, thickens it up, takes a little bit of water, nothing like your HAs, but that's why we get a better look even at 1 week. So this is just a concept. For light skin, right, I might use a CO2, right, because it's light skin. I might use a needle because I think needle is more effective. But when you look at dark skin, if you use a needle, you run the risk of giving them a little bruise. And when you're treating dark circles, for me, it's not logical to risk that little bruise when someone's got dark circles in darker skin type. So that's when I use a cannula, right? It's all about risk mitigation. And when someone's lighter skin, I might use a needle. So these are all concepts where you can combine your energy-based devices, whatever they may be, your PICO, your CO2s, your non-ablative. So to summarize, for eye rejuve, it's really simple. I use cannula or a needle. I use Regerin Eye, and I place the product after an energy-based device. So you asked me, what's the timing, right? So I've done a few publications in regards to EBDs and timings. Ideally, you need to biopsy it, right? Because it gets more complex than that, because your timing of your EBD depends on a lot of things. It depends on the depth of placement of your PNs, your depth of your EBD, so you've got to know your EBD very well, your chromophore absorption, and the structural integrity of PNs with your EBD. So all of these factors have not been elucidated yet in full for all the different EBDs. Now, ideally, to get to this, we should take a biopsy and probably do EM, right? Electron microscopy, just to see the longevity in what the EBD does. So at this moment in time, because a lot of it's unknown, there's so many variables. You know, when you look at fillers, the stability of that, you look at glass index of your PLLAs, PDLAs, it's so complex. And you've got to memorize each of those glass complexes. So for me, advice to you guys, do your EBD after your, PN, right, after your EBD. Now, skin quality improvements, this is what you guys are interested in, how to lighten and brighten skin, right? It has different effects, novel effects in tyrosinase, lightening, increased fibroblast activity, like what we say, but the reflectance of light based on the structure of PN itself. So once again, it's not about, it's just the concept, right, of combining different treatments. So when I do lasers, when I do energy-based devices in, like the stats say, you know, more than 80% of the time I'm combining treatments. And that's based upon logic, right? So this is Pico, but I also needle PN with it as well, with the Regeram. And similar cases with this. Because when you combine your EBD, you only go through one pathway. We all know that with Pico, if we go high settings, we get LIOBs that may generate the collagen. But if you've got scaffold there with your collagen, the end result is better, right? So these are all concepts that I'd like you to understand. So for skin quality, skin brightening, skin lightening, you can use your EBDs. Your Pico lasers, if I'm going to make it really simple, Pico lasers for darker skin, non-ablative lasers for your lighter skin. I use Regeram Classic. Ideally, it would be needle because you want it high up, and the product placed after the EBD. Achuma's made it really easy for me, resistant melasma, right? It's complex, but as you heard from her, it does more than just your tyrosinase inhibition, right? It has novel effects on your melanogenesis, but importantly, it acts as a structure to improve your basement membrane and change your cellular senescence, among other things. Okay, so it does a lot of things for your melasma patients. So we understand that it's not just a pigmentary disorder, it's a photoaging disorder, right? And this is when this is how I pick the patients for Regeram. When we're looking at late onset melasma. Late onset melasma, generally speaking, there's more cellular senescence. It's compromised in your basement membrane, your extracellular matrix is weak, your dermis is photoage. So usually in the more advanced patient, right? Those with early onset melasma with background photoaging, you'll pick those patients as well because you can see photoaging with that, not just hormones, you know, your in brackets hormonal melasma. And then the senescent pigment changes, which you'll see in your Asian patients, right? Which may resemble melasma, but it's not, but it helps as well. And then resistant melasma. So this is just a couple of my cases. 6 sessions of Pico, still resistant, 2 sessions of Regeram, but obviously together with all the other treatments, yeah? So that's where you pick your patients. Once you understand how to pick your patients, your results are very predictable. And late onset melasma with a little bit of pigment dropout. So the concept is this, you know, remodel the dermis, reverse cellular senescence, use all the pathways which you are comfortable with, but Regeram adds to your bioremodeling. So change the pathway of your remodeling. So to summarize, for melasma, your primary modality, like Achima says, is all the other stuff, your medical, your attenuation of your wavelengths, your energy-based devices. I like using Regeram Classic. I use a needle, and I place the product, as always, after the EBD. That's melasma. Pores, very commonly treated in clinical practice, and most dermatologists use for pores for all different types, whether it be high flow oil production, whether it be actinic damage, etc., whether it be genetic. Same concept, right? You're using the same concept where we combine it with the EBD because if it's darker skin type, use your Pico. If it's lighter skin type, use your NA lasers, etc. And that's the same concept. When you provide your ECM with support together with your collagen regeneration, you get pore tightening. Same concept as your regenerative pathways. So in summary, that's how I use it. Redrain Classic, Redrain Scar. I think Redrain Scar works a little bit better, personally, but it hurts a little bit more. It's intradermal, okay? Now, I'm going to spend 2 minutes finally with scarring, right? And Michael Kim has done some really good write-ups on how he uses it for scarring, as well as fat atrophy. But there's a lot out there in regards to scarring with various combinations. I like using the Redrain S. It's got higher viscosity, but there's a way that I use it, which is basically a hydrodissection, very fast push, and it has to be within the dermis itself. Many advantages of using PNs, especially when you're treating high danger areas. You know, like our previous speakers have said, there's no cases of VO, vascular occlusion. So imagine then doing this with a crosslink HA. You know, I don't like doing it, but when you're doing it with PN, your stress levels go to 0. Okay, so there's many advantages. When you use this, get it within the scar tissue. You do a little bit of subcision with your needle itself. If you choose your intradermal scars, give it a firm push because that gives you an element of hydrodissection. So when you pick your scars well, right, you can almost get a very, very predictable response, right? So you've got to select. It doesn't work that well for rolling scars, but superficial scars within the dermis itself, it works very well. But your injection technique matters. I use it in combination treatment, subcision CO2. I also use Redrain as well with this. So this is dark skin type, has advantages, not only with healing, but also its effects on melanogenesis, which means hopefully less post-inflammatory hyperpigmentation. So I do the energy-based device. This is intradermal, very, very superficial. I'm using the Classic just for the volume, that's all. And then whatever's left, I'm using it under. So I call it over and under technique, okay? Now for scarring, this is my summary. Selection is critical. If it doesn't work for you, you've probably selected the wrong patient. It's a superficial injection. And like I said, there's an element of hydrodissection, how quick you push the needle itself, and the viscosity of the injectable as well. So I'm going to summarize with this. Combine, right? My hint to you is combine with all your EBDs. This is the concept of synergy, 1 + 1 = 3. What devices to combine with? Anything you can think of, right? And this is it. This is one take-home slide that you should, I guess, understand, right? Use whatever EBD for your stimulation of collagen, your remodeling. Use it as scaffolding. The end result will be better. So with that, go fish. Thank you.
Thank you so much, Devin. I have a quick question to all of you. Do you think what makes Regeneron different from others regeneration procedures? I mean, other regeneration approach. What do you think? What make Regeneron different? Other PN or other rejuvenation approach?
I think there's more evidence, or like
Okay.
in the world, and simply famous. The name is.
Okay.
I think when you look at the pathways, there's various things. I don't use it as a standalone and say this is the best regeneration approach, but I combine it a lot with EBDs in my practice. Even though there's a lot of data that shows the other pathways, you know, when you look at the EM, it's almost like it's you know, even like Rung Sima says, you know, it's basically your scaffolding, and I think that combined with your primary modality gives you a better outcome compared to just using your primary modality. So I use it primarily for your scaffolding, but all the other effects as well, with your, you know, your breakdown of your polynucleotides and nucleotides, and gives you a little bit of hydrating effect and all the other effects of it.
Okay. So what is your best combination strategy?
I treat a lot of, even though I'm in Australia, I treat a lot of Asians, like probably 80% of my work is Asian patients. And I like using Pico's, Pico laser, yeah, Pico laser. I mean, Pico laser, it's so flexible because you've got that you can reduce your pigment. If you use it in higher settings, you can increase your LIOBs. You can get your collagen regeneration with that. So to me, that's my favorite because the predictability and the happiness of the patient, that's probably my favorite combination.
So when you use with the pickle, because like in Asians, you're Asians too. So basically, after pickle, we have also a problem of rebound hyperpigmentations. So do you think the PN is actually decrease the incidence of rebound hyperpigmentation? The combination is better, or what is your...
My gut feeling, yes. But then we always pre-select our patients, right, in clinical practice. So unless we do de novo patients and a whole lot of them, we can't really tell whether it actually reduces. Because when we see patients, we pre-select. So my gut feeling is that, especially for melasma and acne scarring, where when I use like a CO2 laser, my feeling is that it reduces your PIH as well and rebound.
Okay, but I saw when you please have a question. Yes, question from the floor, please.
I have two questions. The first question is for Dr. Achima.
Yes.
I want to clarify. You said that when you use the botulinum toxin and the PN, you don't combine them in one syringe.
No.
Okay, so the second question is, but could you use them in the same treatment? But I think
Yes.
you mentioned separate
Right.
in between two.
Yes.
Okay. And what is the frequency that you normally suggest for melasma? Once a month? Once every 2 months?
For the PN, I usually once a month, but for the I call it chemoresurfacing, that I would do it every 3 months.
For the botulinum, the
Yes,
combination.
Right.
Okay.
So chemoresurfacing with intradermal toxin like every 3 months,
Okay.
but the PN every month.
Okay. And you still have your favorite take-home medications like
You see-
bleach,
you see-
like whatever you like.
Okay, I treat my patient without bleaching, without whitening for
Okay.
more than 10 years because I believe that melasma is not only pigment.
Okay.
So I believe that melasma is aging.
Mhm.
Is aging is inflammation. So I would treat anything that help for inflammation and aging. So that's why I choose PN to treat melasma because I think melasma is inflammatory disease. So I'm using PN or using other modality, whatever, but not only focusing on just pigment. And I believe that giving a healthier skin is the solution for melasma.
Okay.
So using PN, it helps to remodel the ECM dysregulations.
Okay.
So it has, you get like long-term, you get, you get long-term improvement in melasma. The patient won't have melasma back anymore because their skin is healthier.
Understood.
Yeah.
Okay, thank you. For Dr. Lim, I just want to clarify. Do I understand it correctly? Your first one was for the under eye, and you said you do the EBD after, or is it before
I
the
normally
PN?
do the EBD before, and then it might be a typo. EBD before, and then the PN after.
For all cases.
From all cases, yeah.
Right.
So that's my recommendation. Until we actually figure out what the EBD does to your PN particle, it gets more complex than that because it also depends on the depth of which you put it and the level of which you use your energy-based device.
So to finalize, because I got confused there
Yeah,
because
yeah.
there were two conflicting.
After.
So everything PN comes after
Yep,
EBD.
yep.
So if you're doing it, for instance, every month, so when you say after, can you do it in the same day? Or
I do it on the same day. Yes.
Same day?
Yes.
Okay. Yes. All right. Thank you.
David, do you do priming?
Priming, it just depends on your what I'm priming for, but most of the time, no. If I'm doing, let's say, melasma, I'll treat on the day, but obviously if there's skin quality issues and they come in beforehand, I would prime their skin, get the skin barrier function right, and then use it. I know a lot of guys use it for rosacea as well, but I think it's one of those concepts that if your skin barrier function's compromised, you might prime them for that. But for acne scarring, I don't.
What I'd like to ask you is just, the way that you do the subcision. So you seem like you also inject the tumescent or lidocaine, or what? How do you do it?
Yeah, so so in the beginning, nearly probably all the cases of acne scarring which I do is usually there's some element of surgical case with it. I hardly ever just treat them with an EBD. I like tumescent, and I use quite a fair bit of tumescent. So I published this in Derm Surge, I think about 3 years ago, the technique and the amount of tumescent I use. So for face, one side, normally between 40 to 50 mil of tumescent. Many advantages. Part of it's your hydrodissection because you're trained as well with surgical stuff. When you hydrodissect in different layers, so for me the concept is that I use Regeran to hydrodissect in the dermis, and it's a fast push. I use tumescent to hydrodissect in layer 2, which is your fibroseptal. When I do that, I release some of the tethered scars in your fibroseptal. Importantly, it just gives you so good anesthesia for the rest, which means when I use my EBD or when I inject, the patient doesn't feel anything.
So you see the differences in terms of using this technique or, without the lidocaine. You see any differences in terms of the outcome?
As in the tumescent or the
Yes,
tumescent?
with or without.
With I prefer to use it with because with adrenaline because your bleeding reduces and all that. So I think it really depends on the type of scarring. If it's superficial scarring and box scarring high up in your dermis, you probably don't need that. And in that situation, you just do your Regeran almost as your hydrodissection in layer 1 intradermal. But most of the time, as you know, with scarring, it involves layer 1, layer 2, especially the rolling scars. Yeah.
Because we're just opposite. I'd like to have more blood because I like to have more growth factors.
Growth factors, yes.
So with the subcision, I won't use adrenaline at all.
Yeah,
it's kind of.
I think no, I thoroughly understand
Yeah.
because when you look at the literature, there's that thing about blood as well, and then with Greg Goodman's paper years ago where he actually used vascular laser to change the consistency of blood. I'm the opposite, where I want less bleeding because I don't like doing your when they get your reactive fibroplasia after your subcision. I figured out that I don't like revising those encapsulated hematomas and areas of fibrosis. So for me, my hemostasis is very important. But I guess there are many ways to do this, yeah? So I think it's...
Yeah. Because my idea is when you do subcision, it will be again fibrotic response. So when we do subcision, then we need any modality that helps to remodel a healthier tissue and not go back to healing with fibrotic. And I believe a PNH is perfect answer for this kind of, subcision wound. We have one question from the floor. Sorry.
Hello, sorry. Yeah, hi everyone. I'm Dr. Thang. I'm coming from Vietnam. In Vietnam right now we have a lot of brands with PN and PDIN, and I saw that one thing is that the raw material from the salmon is very important. So I have one question: how does the origin of salmon, such as white salmon or farmer's salmon, affect the quality of PN or PDIN?
Do you want to answer?
I've very limited experience. The reason being is Australia is so slow with our, other things like your Pliness and trout-based device injectables. So the answer to your question, I don't know because I'm limited only by this. But I think it's also your, from what I understand of the literature, it's your how heavy the molecular weight is, how long the chain is. So PN, from what I understand, has got a long molecular chain. And in theory, it's got more structure, more DNA compared to your others. But I can stand corrected. And personally, I've never used the rest because we don't have it in Australia.
Yes, because I had read some paper or some research talk about maybe from the white or white salmon, maybe it contains some protein, and maybe affect about the allergic problem. So that's my
I think you
concern.
can be, my colleague here can comment because I think the allergies is only 4 out of all those cases. Is that right?
Yeah, it's forecast.
We had allergy-related cases for 22, and 4 was severe. 4 was anaphylaxis-related.
It's forecast.
Yeah.
Yeah.
Between the all cases was. I'm sorry. All cases. Sorry. The reported cases was total with 78,552 cases, and we only had 22 cases for allergy-related cases and 4 severe anaphylaxis-related. So,
With Rigeran?
yeah, for per day, for 78,552 people we recorded last year.
48,000?
48,000.
78,000.
78,000 people.
Yeah,
And then you get how many people who get allergic reaction?
22.
22.
22.
Only 22
Okay,
last
severe.
year.
How severe of immunologic reactions?
Not details, but 4 had anaphylaxis related, but all of them survived.
Really?
What was is it related to fish allergy or anything? Because this is what everyone asks, yeah.
The detail was not reported, so I can't say the exact answer. I'm sorry.
I'm sorry, the data is coming from where?
From our internal report, from SBC Medical Group internal report.
From in your country?
Yeah. From our in my country SBC Medical Group data.
Because like in Thailand, we never have any problem immunologic reaction at all. So I think we have, yeah.
Yeah, certainly in Australia, we have never come across anaphylaxis, and I think I'm part of the medical advisory team. I haven't heard of it, but maybe it's, I don't know, I haven't heard of it either. No allergies.
Yeah, maybe.
Interesting.
Yes, interesting. Maybe we have to look into whether it's a fake product, because a lot of fake products out there. Yeah. Right. Okay. I think we ran out of time. Almost 1:30 already.
Thank you.
Thank you. Thank you, everybody.